If you want to become a very strong NICU nurse, it helps to start with understanding how your baby's assessment correlates with their condition. Asking the why behind the condition and what you are seeing is going to help you start anticipating needs in future patients and making really strong recommendations and advocating for your patients. So today we are going to be discussing Meconium Aspiration Syndrome, which can range from extremely mild to very, very severe. These babies even have the possibility of ending up on ECMO. We are going to be discussing what Meconium Aspiration Syndrome is and the pathology behind it. We'll discuss what you should be focusing on as your priority, whether you're the nurse down at the delivery for a patient with MAS or assessing them up on the floor. We'll talk about complications that commonly occur with Meconium Aspiration Syndrome, like pneumothorax and pulmonary hypertension. And then I'll give you a couple examples of critical thinking in MAS patients. Before we get started, my name is Liliana. I've been a NICU nurse for 3 years, and my whole goal on my TikTok and YouTube and Instagram is to help nurses begin to think critically about their patients and to develop a really strong sense of confidence as a NICU nurse. So if that's something you're interested, definitely go ahead and subscribe below. I'm going to have timestamps in the description of all of the topics that I just mentioned, so if you want to skip ahead to one part of the video, you can. But without further ado, let's get into it. So to start, MAS or Meconium Aspiration Syndrome occurs when the baby breathes in some meconium stained fluid into their lungs. That stained fluid being the amniotic fluid that baby has been living in. Typically, this isn't something you are going to see in a little 25 or 26 weeker. These babies are usually close to term, if not post-term. And oftentimes they have had a stressful delivery or a stressful labor that has led the fluid to become stained with meconium, meaning they essentially pooped while still inside of mom. And then as they were coming out, they took a big gulp of that fluid. Because meconium aspiration kiddos can end up super sick, there is almost always a NICU delivery team member at one of these deliveries where the amniotic fluid is stained with meconium. So why can these babies end up super sick, or why is it a problem? If you have ever changed a meconium diaper, either as a parent or as a NICU nurse, you know that it is super thick and sticky. It's oftentimes compared to black tar. Because it is so thick and sticky, it can very easily clog up the airways. That thick, sticky meconium can get into the airways on inhalation, but the problem is on exhalation, it can't get out. This can cause air trapping, leading to an over distension of the lungs. So on x-ray, the lungs are going to look hyperinflated, and it also increases the risk of an air leak developing in the form of a pneumothorax, which we will talk more about the signs of a pneumothorax later, but just know that that is the patho behind why that can happen. It can also just completely shut down some of those small alveoli, leading to atelectasis, so you can have hyperinflation with atelectasis. The other reason that things can go wrong is because meconium deactivates surfactant. And if you're a NICU nurse, you know how important surfactant is. If you don't know, surfactant is a fatty substance made by the body. It exists in the lungs and helps keep alveoli open by reducing surface tension. However, when meconium gets in there, those bile salts and fatty components of meconium can essentially deactivate surfactant. This then further contributes to the atelectasis, and it reduces overall lung compliance and the exchange of oxygen and carbon dioxide. And then, as I'm sure you can imagine, meconium is going to trigger an inflammatory response by the lungs. In response to this, the body is going to release all kinds of things called cytokines in order to respond to the inflammation. It's the body trying to help, but ultimately it's going to further damage lung tissue. This inflammation can also cause the blood vessels in the lungs to constrict, leading to a high pulmonary vascular resistance, which is going to be pulmonary hypertension. And then it just becomes a vicious cycle, right? Because then the PDA is going to develop a right to left shunt, which is only going to worsen the high pressures in the lungs, leading to this damaging cycle where the pulmonary hypertension is just getting worse and worse and worse. And that's how these kids can end up needing ECMO. So now that we've covered the patho behind MAS, what determines the severity? Because like I said, this can range from very mild to extremely severe. A lot of it has to do with how thick and how much meconium ended up in baby's lungs and the timing of when this occurred. Because yes, this can occur while the baby is still in utero. The baby can aspirate this fluid in utero as they are coming out or immediately after delivery. The labor team usually does its best to limit the amount of aspiration that baby is going to have as they are coming out or immediately after. Typically, aspirations that occur in utero are the most severe. And then it also obviously depends on how thick and how much meconium this baby aspirated. Some meconium stained fluid may be very mild, others may be extremely stained with a lot of thick meconium. These factors are all going to play in with the severity that you see in your patient. As I said earlier, there will usually be a member or team from the NICU called down to a meconium aspiration delivery because of all the risks associated with it. Even if all we know is that the baby has mild meconium stained fluid, because the risk is just so high and we'd rather be safe than sorry. So if you're the nurse that is delivery trained and is going to this delivery, what are some of the things you may see on initial presentation? Some red flags would be this baby coming out grunting, retracting. Maybe they are blue or cyanotic. Maybe they need oxygen right away. Maybe it means they require PPV right away because their respiratory effort is not strong and their heart rate is below 100. Now, a while ago, there were recommendations that these MAS babies should be deep suctioned right away. Now, routine suctioning is not recommended. Now, the recommended approach to managing these kids in the delivery room is going to be prompt use of NRP, just like we would for any other patient. This is just to help minimize any harm and delays that may come from us waiting to initiate NRP while performing this routine deep suctioning. This deep suctioning should only really occur if we are having ineffective PPV and worried about an obstruction. And by this point, the provider and the RT may be moving to gather things for intubation anyway. But just remember, even though in your mind it might make sense to immediately perform a deep suction, that no longer reflects the current guidelines. And suctioning can be harmful too, right? It can cause a lot of trauma and it can delay us providing effective breaths for this baby. So that's why the recommendations are where they are today. And of course, if this baby definitely comes out non-vigorous, you will always have backup team members available to be called or already down there with you, such as an RT, a nurse practitioner, a neonatologist. So lean on your team and remember that you are not alone in this situation and making decisions. Moving on to complications. Now, we discussed the two biggest complications you are going to see from MAS, which are pneumothorax and pulmonary hypertension. But let's talk about what are some of the signs and symptoms you are going to start seeing in your baby if they are developing one of these complications and why. Remember, with a pneumothorax, that air is trapped and those lungs are super stiff. This can cause a leak leading to pneumothorax. If you are all of a sudden noticing that your patient is desatting, not coming up with O's, having worsening work of breathing, if you notice asymmetrical chest rise or you listen and do not hear bilateral breath sounds, I want you to think pneumothorax and get a chest x-ray ordered and a provider at the bedside ASAP. Again, you're not the one making that call, but it helps to anticipate needs. And if I notice a big desat in my baby that I know had Meconium Aspiration Syndrome, the first thing I'm doing is I'm listening for bilateral breath sounds, watching that chest. A lot of times NICUs will have a transilluminator you can put on the chest and see what the air is looking like in there. But ultimately, if you are concerned, call a provider to the bedside immediately and get an x-ray ordered. And of course, the other big one is pulmonary hypertension. With these babies, you are going to want to look at a pre and post ductal sat. So we know that pre-ductal is going to be on the right wrist and post-ductal is going to be on either of the feet. This just has to do with where blood goes with the PDA. Pre-ductal is going to be before the duct because there are branches off of the aorta that go to the right side of the body and the brain, and branches off of the aorta that are after the duct that go to the rest of the body. If you are noticing a greater than 10% difference between your pre and post-ductal saturations, it's likely that this baby has developed pulmonary hypertension. Oftentimes, a provider will order an echo to confirm this. If your baby is experiencing pulmonary hypertension, they will probably have pretty low oxygen saturations and be working pretty hard to breathe. So even if your provider didn't order for pre and post ductal saturations, you can always grab another pulse ox, put it on the right wrist and one of the feet, and just check to see if there is that greater than 10% difference, that you can advocate for your provider to come assess this patient. And the other complication I briefly wanted to talk about is pneumonia. Obviously, this is meconium, it's in the lungs. There is that possibility of an infection. So if your baby is getting worse, maybe their blood pressures are a little bit low, maybe you don't love their color, or all of a sudden they're acting a little bit different. A lot of things in NICU come back to infection. So you can always advocate for your provider to come assess the baby and recommend an initial infection screen, maybe a chest x-ray to rule out any pneumonia that may be going on. I also briefly wanted to mention why these babies can end up on ECMO. I'm not going to get into all of the details of ECMO because I think that is a little bit too advanced for this type of video, but essentially when the Meconium Aspiration Syndrome is severe enough that the baby just cannot get enough oxygen into the blood that is circulating throughout the body, they're having hypercarbia on their blood gases, so high CO2s, and experiencing a profound level of hypoxia, despite all of our interventions we can do, then these babies may end up on ECMO, which is not a treatment in itself, but it does bypass either the lungs or the heart and lungs, giving the body time to heal itself from this Meconium Aspiration Syndrome. Fun fact also, the very first baby that ever went onto ECMO was an MAS baby, and she did survive. Some other more common interventions you may see done on these patients would be inhaled nitric oxide if they are experiencing high levels of pulmonary hypertension. Sometimes these babies end up on a ventilator, a traditional ventilator, or an oscillator, which the oscillator is sometimes used especially as we are creeping up to getting near that ECMO range. They may try the oscillator. Basically, a lot of the focus on the treatment for this is just making sure that we are managing our blood gases appropriately. Providers will be adjusting vent settings frequently based off of blood gases and allowing the lungs time to heal. I have seen providers treat with surfactant that we put into the lungs if the meconium is interacting negatively with the surfactant that the baby made on their own. Every situation is going to be so different depending on how severe this MAS was and other things that may be going on with baby, but that's a quick rundown of a couple treatments you may expect to see. So where can your critical thinking and what you learned in this video really help you take the best care possible of your NICU babies? Don't just react to the monitor. Always look and assess your baby and think about why this DSAT may be happening, especially if it's a significant one. In an MAS kiddo, I am almost always thinking of pneumothorax if my baby is experiencing a sudden dramatic desaturation. As I said earlier, you can go ahead and listen to the chest, use that transilluminator if it's available, get some help to the bedside. You're probably going to be drawing frequent blood gases on this baby, so anticipate vent changes if your acidosis is worsening. Maybe even as you're climbing in pressures on a conventional ventilator, anticipate that the provider may be thinking of switching to an oscillator. If your baby is experiencing pulmonary hypertension, meaning you went ahead and checked those pre and post ductal sats and called them and let them know that this was happening, maybe anticipate that nitric oxide would be started. As nurses, we assess, but as great nurses, we learn to connect the dots between our assessment, the possible causes behind it, and what interventions we can do as a result, and how to communicate effectively with providers. That is how you become more than just a task-oriented nurse. You are becoming an advocate for your patient and a strong member of the NICU team. Okay, so to summarize, MAS, or Meconium Aspiration Syndrome, is when a baby breathes meconium into the lungs before, during, or after delivery. It can cause blockages in the airway, air trapping, inflammation, and pulmonary hypertension, and can interfere with surfactant. We are going to monitor these kiddos, perform NRP as indicated if you are going down to the delivery, anticipate complications ahead of time, and advocate when something doesn't look right. Keep staying curious, and remember, don't just do the task. Ask yourself why you are doing it and what it means for the baby. That's how you grow your critical thinking in the NICU. Thank you guys so much for hanging out with me and talking all about MAS today. If you found this helpful, make sure you like and let me know in the comments. Subscribe for more NICU nurse content and share with new NICU nurses that may need this information. Thank you guys so much, and I'll see you next time.